Perfect. Okay, so thanks everyone for coming to the IQ Forum for today. Again, my name is Stacy Farr, and I'm one of the co-directors of the Healthcare Institute for Innovations and Quality. Today, we're talking again about opportunities and challenges in rural health, and we have a really great lineup of speakers. So excited to get started. So I'm going to share just a few slides before we dig into our agenda today. And I do just want to remind everyone that we really want this to be interactive and hear from everyone. So please do put your questions in the chat where we'll have a Q&A session or section at the end where we'll talk about this and have a good discussion. But we really also love to keep dialogue going in the chat. So please, we do welcome you. So first, I'm just going to share a few slides. So first, we want to thank the IQ Forum. We want to thank all of our valued partners. We have a number who support us in a number of different ways, including BioNexus KC, Health Forward Foundation, Frontiers Clinical and Translational Science Institute, and UMKC, University of Missouri, Kansas City. And to share just a little bit of background about the Institute, we do have this vision of Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission and the way in which we really go about this is, catalyzing and facilitating multi-stakeholder collaborations to improve the quality, value, and equity of healthcare in the Kansas City region. And we do this with really three key aims. So our first is really that we want to reduce costs for all involved. We know this is not just, when we say healthcare costs, this is including the patient's perspectives from payers, from providers. We also are really wanting and aiming to improve the quality of care and the experience for both patients and providers, as well as creating greater equity in healthcare delivery for the Kansas City region. And to share with you all, one of the main bodies of work that we all do at the Institute is healthcare improvement in terms of quality improvement, where we work on regional implementation and measure the outcomes as well. And so for many of you that know, our first phase 2 projects were our opioid management project, which was engaging patients in care coordination, helping support the implementation as well as the evaluation. And then our second project, which is still ongoing, is our transitions of care for heart failure, where we have a number of initiatives that we're implementing across different hospitals across the Kansas City metro in terms of the heart failure carousel, as you see there. So whether patients are, in the ED, coming to ED with their heart failure symptoms, or they're admitted or transitioning home, or a social determinants of health intervention that we're focused on to deliver services for patients once they go home and need to be able to maintain their health. And we're moving into our phase 2, which is in maternal mortality, where as we all know, maternal mortality and inequities are really pronounced, especially when you look at all these OECD countries, and at least some trends that are starting to go downward in terms of maternal deaths per 100,000 live births. But if you look at the outlier, it is us, unfortunately, the USA, and here up is not good. So we're really excited to start working with our regional partners on both sides of the state line to implement some initiatives in our region. And then this is our IQ Forum, which is just our schedule for this year. I'll share next year's shortly, but we are here today where we're in our final one of the year, where we're talking about opportunities and challenges in rural health. And as we know, I probably don't need to read all of this, but really that we know that there are a number of challenges that people face when they're living in rural areas, particularly related to healthcare providers, medical facilities, transportation, different rates of chronic conditions we see. And, this is, there's a number of ongoing challenges, and I think the speakers today will do a really good job of highlighting those for us. I do want to share just, I know one of our speakers is also here and works with the RHI Hub, but did want to just share a couple things high level to show, at least in our region, from this really great, the RHI Hub, the Rural Health Information Hub, which uses the Institute for Health Metrics and Evaluation data, which is great, but and available at their website. But, when you look at life expectancy, at birth, and this is just a map, and where dark is bad here, where lower. And if you look, you're obviously not going to be able to read all of those, but that shows you, at least by state. But what I think is interesting is when you look at, the US as a whole, when you compare metro, to non-metro, you can see that obviously non-metro have a lower life expectancy. And then when you look at that within our region, in both Kansas and in Missouri, we see that those inequities are also present there. So that's, just life expectancy. And then taking just a different one when we think about access to care and the number of MDs per 10,000 people. Here, light is worse, where we have a lower density of doctors per 10,000 people. And where we see, at least according, the US as a whole, we see that non-metro, look at the basically threefold difference. And then that is similar for Kansas and even worse for Missouri in terms of the number of physicians that are accessible to people living in rural areas. So just highlighting very high level, we'll hear from our other speakers today, a lot more detail about this, but just wanted to share a couple high level metrics in terms of quality of care outcomes and access. But today we have a really wonderful lineup of speakers we're very, very privileged to have here. So the first of which is Lorraine Burton, who's actually first on my little screen over here on her face, but providing a public health perspective for us on quality improvement efforts in critical access hospitals across the country. And she's with HRSA, so very lucky to have her. And then we'll move into hearing the pharmacist and prescription drug benefit perspective, Pharmageddon, which is just phenomenally named, with Darren Price. And then we will hear a nurse practitioner perspective from Doc Hollywood to Virgin River, Misconceptions, Realities, and Opportunities in Rural Medicine from Kelly Swaden. And then a physician journalist perspective from Kay Miller Temple. So we have a really wonderful lineup of speakers. And so with that, I will stop talking and I will allow Lorraine to take over.
Thank you, Stacy. Are you able to transition my slides for me? If not, I have a backup plan.
I am looking to see if Pat is able to share slides. I don't have them, but Pat might. And I know she's on the Zoom, so at least,
Okay.
And she can hear.
Okay.
Awesome.
Perfect. Thank you so much. All right, so good afternoon, everyone. As Stacy mentioned, I'm Lorraine Burton, and I'm with HRSA's Federal Office of Rural Health Policy. I'm the program lead for the Medicare Beneficiary Quality Improvement Project, otherwise known as MBQIP. Today's presentation intends to highlight quality improvement efforts in critical access hospitals across the country. During this presentation, as Stacy mentioned, if you have any questions, please feel free to drop them in the chat, and we'll do our best to provide answers during our segment. And for the questions we don't get to, please feel free to email me. My contact info is provided on the last slide of this presentation. Next slide, please. Okay. The Federal Office of Rural Health Policy, otherwise known as FORP, at the Health Resources and Services Administration, HRSA, collaborates with rural communities and partners to support programs and shape policy to improve health in rural America. Next slide, please. As of today, 45 states within the U.S. support 1,369 critical access hospitals, otherwise known as the acronym CAUS. For reference, a critical access hospital is a designation given to eligible rural hospitals by CMS. The criteria for an eligible hospital to be considered a critical access hospital must meet certain conditions, in that the facility is a small rural hospital with 25 beds or fewer and is 25 miles or more from another hospital. These hospitals, because of low volume issues with data collection, are exempt from CMS quality reporting requirements, which is why we vigorously encourage the expectation of quality reporting, leading to an upward trajectory for better patient outcomes and reduced burden. Next slide, please. Through the federal office's Medicare Rural Hospital Flexibility Program, known as FLEX, the goal is to improve the health of rural communities by ensuring that high-quality healthcare is available in rural communities, as well as aligned with community needs across states that are designated as a critical access hospital. Through funding, the federal office enables states to support critical access hospitals in quality improvement, reporting, performance improvement, and benchmarking. Notably, the State Flex program spent approximately $11.6 million on quality improvement work, which is about 42.8% of the budget, to support the Medicare Beneficiary Quality Improvement Project, known as MBQIP. Next slide, please. The purpose of the Medicare Beneficiary Quality Improvement Project, otherwise known as MBQIP, as previously mentioned, is to improve the quality of care provided in critical access hospitals by increasing quality data reporting and driving quality improvement activities based on the data. MBQIP provides an opportunity for individual hospitals to examine their data, measure outcomes against other critical access hospitals, and partner with other hospitals in the state around quality improvement initiatives to improve outcomes. And I would be remiss if I didn't point out that prior to MBQIP, quality improvement activities for critical access hospitals did not exist in the federal space. So this said, and especially since critical access hospitals are exempt from CMS quality reporting requirements, as previously mentioned, the establishment of the MBQIP project robustly encourages a quality center focus. Next slide, please. This slide displays our measure selection process. The federal office at HRSA adopts MBQIP measures based on national alignment with CMS and CDC based on their quality measured standards. We also take into account considerable input from our federal office, our state flex programs, critical access hospitals, and a public comment process. Here you can see that we went from 8 measures to 6 because 2 of our outpatient measures are being retired by CMS, and we really don't have control over that process. So with MBQIP, what we're trying to do is encourage all critical access hospitals to report on all measures just so that they can demonstrate their quality of work. You can see here that currently only a little over a third of hospitals are reporting on all the measures. So this is something that we're actively working on, essentially trying to get the numbers up for more of our hospitals to report on more measures. Next slide, please. This slide shows our MBQIP core set, kind of building from the existing MBQIP measures that I just explained in the previous slide. Our MBQIP core measures are organized in 5 domains: global, patient safety, patient experience, care coordination, and the emergency department. Of the 12 measures in total, 9 of the measures are reported once annually, and 3 of the measures are reported quarterly. Next slide, please. So this slide deck shows a 4-year trend of the percentage of critical access hospitals reporting at least one patient safety inpatient measure. And given our goal is to increase these reporting percentages year over year, you can see that in 2022, the percentages were higher over the past 4 years. Next slide, please. Just another sample to show our trends here. This diagram does show the percentage of critical access hospitals reporting at least one outpatient measure between 2019 and 2022. And again, the percentage of critical access hospitals reporting on at least one outpatient measure over this 4-year trend has progressively increased. Next slide, please. This is our HCAHPS trend slide. This diagram shows the percentage of critical access hospitals reporting at least one HCAHPS measure based on the patient engagement. And so here you can see that in 2022, 94.6% of critical access hospitals reported quality data on at least one patient engagement measure. And again, this is an increase over a 4-year trajectory. And this does demonstrate here that, we are moving in the right direction, and we want to keep seeing those numbers go up. Next slide, please. This slide is just a quick resource here. The one that I wanted to point out is the MBQuip overview. If you click on that link, it'll take you to HRSA's MBQuip page, where you can learn more about our MBQuip project, as well as find my contact information below. The other resource is going to get you to the MBQuip core set landing page, where you can take a look at our measures and see, look at the measure descriptions and the different indicators involved in it, and some other resources as well. And then that last resource is a CMS knowledge booklet, where you can learn more about critical access hospitals if interested. Next slide, please. Now, this is our last slide, and it does conclude the presentation on quality improvement efforts in critical access hospitals across the country. I hope you found this presentation informative, and please feel free to reach out with any questions you may have. My contact information is displayed here on this slide. I want to thank you all, and thank you, Stacy.
Yes, thank you so much. That was really great. Really appreciate that presentation. And yeah, just a reminder, anyone, you can put any comments or questions in the chat. We'll keep that going and we'll address those at the end as well. But now we'll, I guess, move to our next speaker. So now my pleasure to introduce Derek Price, who is president of Price Pharmacies and owner of OreadRx.
Oriad.
Floor is yours.
It's
Oriad. Okay,
close.
thank you. I was like, I knew I was going to say it wrong. I should have done that.
Close. No problem. Thank you so much, Stacy. I appreciate the opportunity to be here. Pat, I assume you'll do my slides as well.
Oh, Darren, no, only if you want me to. You're welcome to share your slides, but I'm happy to slide jockey if you want me to. Lorraine had asked if I would do that for her because of her notes.
Let me see.
I'm happy to. Do you want me to pull yours up?
I can share it if that's okay.
Yeah, absolutely.
Can you see this okay?
Not yet. There we go. And if you could go into
when I start
presentation.
this, let me make sure when I start the slideshow, can you still see it?
No.
Went away. Okay, I can just do it like this. So is this okay? Everybody see it okay?
Do you want me to try from mine? Because that's a little small. Do you want me to try from
Well,
my desk?
yeah, if you don't mind, that'd be
I
great.
don't mind at all.
Let me stop sharing here.
1 second.
Sure.
You have to stop sharing.
Oh, got it.
Whoops. 1 second.
Glad to hear your voice now, Pat.
I had to undo a whole lot here. I don't, I have to take this to IT and get them to figure that out, but share. There's Derek. And let's
Good thing there's a lot of computers. We could at least get some workarounds to get going.
there you go.
Okay.
You're all set, and I will just let me know when you want me to go to the next slide.
Okay, perfect. Yeah. So thank you guys so much for having me on today. This is a very complicated issue, and so I'm going to do my best to describe it to you really quickly, but I'm going to kind of fly through this presentation. So my name is Derek Price. I'm a pharmacist, and I own 8 locations in Kansas. Also the owner of OreadRx, which is a transparent pass-through PBM. So the term Pharmageddon is a little catchy, but it is a phrase that has described what's happening in the pharmacy space right now. I think, and I'll show you a little bit later in the presentation about what that is, about the pharmacy closures and what is happening, especially in rural America right now. So with that, we'll just go ahead and get started. Pat, next slide, please.
I am next sliding it, and it is not going.
Not moving.
There.
There went. Okay, awesome. So really four things we're going to focus on today. Drug spend in the US and what it has done recently, the pharmacy marketplace, the pharmacy benefit managers and what role they have in all of this, and then some solutions of what can be done. And then at the very end, kind of a shameless plug for Oriat RX and some of the things that we've been doing. So next slide, please. So drug spend in the United States, I'm going to show you a couple of graphs here in a minute to describe what's happened. But a couple of things worth noting is the United States is the only country in the world that has pharmacy benefit managers who are companies that are supposed to be managing pharmacy spend. Drug spend in the United States when compared to other developed countries is 2 to 4 times higher than all of those countries. And we have seen a significant increase since the year 2000. Next slide, please. So if you look at this trend, and I know this is a little bit hard to read, but drug spend in the United States was very stagnant from 1960 to about the year 2000. The year 2000 and on, it has just absolutely exploded and to where we are today. And this trend is going to continue. It is estimated between 2024 and 2034, drug spend will increase another 57%. Next slide, please. So this just kind of hammers home the amount that drug spend has increased since the year 2002 when it just absolutely took off. So it has tripled just in a short period, whereas it had stayed stagnant for 40 or 50 years beforehand. So we are spending way too much money on drugs in the United States, obviously. And so one would think all this drug spend that pharmacies would be absolutely thriving, right? But we see that's exactly the opposite. So next slide, please. So pharmacy closures in 2024 so far. So around 2,300 pharmacies have closed this year alone. That equates to about 4 independent retail pharmacies a day, which a lot of times are located in rural communities. But even 5 chain pharmacy locations close every single day here in the United States. Walgreens announced a few months ago that they're going to be closing 1,200 stores in the next 3 years, which is about a 25 to 30% reduction in the number of stores that they have in the United States. And here in Kansas, and I think this actually changed since I made these slides, but 11 pharmacy closures so far here in Kansas this year. I think we're probably closer to around 15 now. So next slide. So sadly, what we see is pharmacies that have been around for 80, 90, 100 years actually going out of business. And a lot of pharmacy consolidation in the marketplace as well. Next slide, please. And so again, kind of hammering home, Rite Aid is shutting down 27 locations and 550 of those nationwide. Next slide. So this is just a map of the pharmacy closures that have happened in the last year. So next slide, please. So why? So we're spending more money on drugs than ever before, but pharmacies are closing. So what's going on there? Next slide, please. So in comes the role of the pharmacy benefit manager. Pharmacy benefit managers have been around for a really long time. They were initially brought to market to help with real-time benefit. So you go to the pharmacy counter and you know exactly what your copay is, right? And what your insurance is paying for a drug. And so that allows you to pay that copay there at the pharmacy. Other things that pharmacy benefit managers do is they set formularies. So they determine what drugs are available to you that are covered on your health plan. They determine what your copays are. They also determine what the pharmacy is paid. They determine what the pharmacy network is. So who all gets to participate from a pharmacy standpoint in the network. And they also apply for rebates on branded and specialty drugs. So next slide, please. So I want you to think back to one of the first slides, that graph that showed a stark increase in the amount of drug spend around the year 2000, okay? And I believe this is not a coincidence. So in the year 2005 and 2007 were the first times that the FTC allowed insurance companies to buy pharmacy benefit managers, okay? So that happened in the year 2007. Since then, you can see all of the mergers that have happened in this space. Okay. Why did this happen? Why did insurance companies just start to decide to buy pharmacy benefit managers? It was because they knew there was no regulation in the pharmacy benefit space. There are certain rules that revolve around how much of premium have to be spent on the medical side. You have to spend a certain amount of that premium goes towards patient care, right? But there are no such rules on the pharmacy benefit side, and insurance companies were smart and understood that, and so they found a way to buy these pharmacy benefit companies, and then and that it greatly increased their profit margin. So next slide, please. So these are six mega insurers, and this shows, I know it's a little bit hard to see, but this shows vertical integration. And so these companies not only own, the health plan or the health insurance, they own the PBM, they own specialty pharmacies, they own retail pharmacies, mail order pharmacies, and now providers as well. And so these six companies control 95% of the insurance market. So next slide, please. So why is that a bad thing? So when a company is vertically integrated, you can no longer choose your partners. So when you sign up with a major health insurer, they have all of the pieces to the puzzle that you have to use. So from a PBM standpoint, if you decide to get your health insurance through United Healthcare, you have to use Optum Rx, which is owned by United Healthcare. Okay. So you're basically forced to use the pharmacy benefit manager that is owned by that health insurance company. So here are some of the top ways pharmacy benefit managers make money. So rebates is the amount of money that is paid by drug manufacturers to the pharmacy benefit manager to be added to the formulary. Okay, so Humira is an example. They would work with the PBM to say, we're going to give you a 50% rebate on Humira, which is an $8,000 a month drug. So $4,000 is going back to the PBM. Now, what happens to the $4,000 after it hits the PBM is up for debate. Some of that money trickles back to the employer, but most of that money is retained within the pharmacy benefit manager. Spread pricing is the difference in what the pharmacy is paid versus what the health plan is charged. So we see this all the time. So health insurers will, whenever you go to sign up for the health insurance, they say they have a PBM that has a $0 administration fee, but they're going to invoke their spread pricing model. And so what that looks like is when you go to the pharmacy to pick up your medication, the health plan, or you may pay $5 for that medication, and the health plan pays $0 for a cheap generic medication. So what's happening right now, though, is then the PBM turns around and charges the health plan $100 for that same transaction. So they're charging the health plan $100 and only paying the pharmacy $5. So that's $95 in spread pricing, and that's just money that the PBM makes. So then also steering is another way that they make money. And so almost all specialty medication is filled by PBM owned pharmacies. This is a big deal because specialty medication has completely taken off in the United States and has resulted in some of that increase in drug spend. And we see it all the time that the health plan or the health insurance will try to steer people to their own pharmacies that are owned by the health insurance company. So next slide, please. So this is an example of steering when steering happens. So this tadalafil 20 milligrams, a common drug, generic Cialis. So the white areas on here are when it was filled at either a chain pharmacy or a local independent pharmacy. And the brown areas were when it was filled by the mail order facility that is owned by the health insurer. Okay, and so I'll call your attention to column E. So you can see when that prescription is filled by the pharmacy that is owned by the health insurance, the health plan pays $8,000, $8,600 for that prescription. But when it's filled at a chain pharmacy, the health plan is charged $4,000 for that same medication. And then when it's filled at a local independent pharmacy, the health plan is charged $2,000. So basically, they're paying themselves sometimes up to 4 times what they pay other pharmacies. So next slide, please. So that's, going back to the 4 things that we're talking about, drug spend is so high. Pharmacies are going out of business. PBMs are playing a big role in the increase in drug spend and putting pharmacies out of business. So what can we do about it? So legislation is one thing. There's a lot of heat on PBMs today. I don't know if any of you have been following it, but there have been 3 sessions in the House Oversight and Accountability Committee with the big 3 PBMs with questions about their practices. There's been reports by that committee that the PBMs actually are costing the system money and not saving them money. And then right now there's over a dozen pieces of legislation out there trying to fix the problem. It can also be solved with state legislation. A few years ago, there was a Supreme Court case, Mulready versus Rutledge, or no, I'm sorry, Rutledge versus PCMA is what it was. And that gave states the ability to regulate PBMs. And so there's a lot of things going on the legislation side right now. Fair market adjustments. So that's where Oriad RX comes in, our company. A lot of people are tired of their healthcare premiums going up 10, 12, 15, 20% every year. And so they're looking at doing things differently. The New York Times and Washington Post have spotlighted a lot of the things that I've talked about today in some articles. And a lot of companies are deciding to go self-insured now and using when you go self-insured, that allows you to unbundle and choose your different vendor, not just use the vertically integrated company. There's also an ongoing FTC investigation. FTC has previously advocated for PBMs, but after seeing their practices the last several years, they've actually pulled back that statement. And they actually just filed a lawsuit against Express Scripts over insulin inflation. And so there's a lot going on. And so these are just a few solutions to the problem. Next slide, please. So Oriad RX, so this is a little bit of a shameless plug. We started back in 2019, and the reason why we started was all of my local employers kept coming to my pharmacy saying, "Hey, we can't hardly afford healthcare for our employees anymore because of drug spend." They say my premiums are going up because of drug spend. What's going on here? Well, and I just looked at them and said, "Well, I'm getting paid less than I ever have before." So premiums are going up, employers are paying a lot for health insurance, and pharmacies are getting paid less today than they ever have been. So where's all the money going? And I hope I have described where that's going, and it's with the pharmacy benefit management companies. And so we started Oriad RX. It's a true transparent pass-through pharmacy benefit company. We're not the only one out there. There are several others out there. But we don't do anything that the big PBMs do to hide money. We just charge a flat admin fee for our services. So next slide, please. So one example of what this can look like. So this was a client, they're a local rural hospital. They were using a vertically integrated health insurance, very popular one in Kansas. And they decided to unbundle, go self-insured and switch. And so if you can see, I think this was back in 2020 is when the switch occurred. They were spending $738,000 on medications annually through their health plan. And fast forward a couple of years later, after they've been with Oriad for 2 years, they've saved over $267,000 just on their prescription spend. And so, and that's because we have to do a good job. We're just one of those vendors in the pieces in the whole of the health insurance. And so we have to be accountable and an actual fiduciary to our client. Not just hide behind a vertically integrated network and overcharge the client. So this is what it can look like whenever you use a pass-through transparent PBM and unbundle from the big health insurers. So next slide. Okay, yep. But I had one more, but that's it. So thank you so much for all of your time today. And I would be happy to answer any questions later. Thank you.
Thank you, Darren. Very,
Yes, thank you so much. That was alarming and wonderful in terms of the presentation. So our next speaker will be Kelly Swayden, who will be providing a nurse practitioner perspective. And the floor is yours.
All right, can you hear me?
Yes.
Can you hear me?
Yes.
Okay. Is that better?
Yeah.
We still got an echo going on here.
here, I got you.
Yeah, I think just have
Now.
All right. Yeah, perfect.
perfect.
There we go. All right. From Doc Hollywood to Virgin River, misconceptions, realities, opportunities, and challenges in rural medicine. I hope some of you are old enough to remember, like I am, the 1991 film Doc Hollywood, where Michael J. Fox plays a big city doctor just graduated from med school on his way to plastic surgery fellowship in Los Angeles, gets in a car wreck on his way through Grady, Alabama, and is stuck there providing rural medical care to the citizens until he works off the debt from the fence he ruined and his car is able to be fixed. And then more recently, Virgin River, kind of a similar story, Mel Monroe, nurse practitioner who leaves California and starts her life over in a rural town called Virgin River. And these stories are familiar to me because I too am from a small town, practiced medicine in Kansas City for 20 years, and then decided to change course and start practicing in rural hospitals throughout the Midwest. Next slide, please. I feel like when people think of rural medical providers, they think that either it's a college med student working off debt who needs that loan repaid, or a physician who really couldn't practice, wasn't qualified to practice anywhere else. This character from Virgin River says, I didn't have to come back. I chose to come back because medicine had become too much paperwork and politics and not enough doctoring. Next slide, please. And Dr. Halberstrom from Doc Hollywood, you went down there to get that small town chip off your shoulder, didn't you? You're a braver man than I am. For me, I did feel that corporate medicine had become too much about quantity of patients seen and not quality of care. There was a lot of paperwork, a lot of fighting with insurance companies, and a lot of parting people out to the specialties they needed to go to without great continuity of care. Next slide, please. So between that and a culmination of events, 2016, my 98-year-old grandpa was in long-term care and was showing signs of a urinary tract infection. I was practicing in Kansas City and was trying to coordinate his care with a local provider. And it took days to get him tested for a UTI. When he was already in renal failure, had to be admitted, was placed on Keflex. The culture showed that he was resistant to Keflex. The provider didn't change his medication to a correct antibiotic because he was laughing, talking, and seemed more alert, and went into complete renal failure by the time a new provider stepped in who was moonlighting from Wichita, Kansas, and was able to talk to a nephrologist about my grandpa's case, get him on the right track, fluid resuscitation, the right antibiotic, and talk to me to coordinate his care. And we were able to get him fixed back up and back to his home. And secondly, our dear friend and local attorney, Bob Christensen, was riding his bike in 2019 down a highway in my hometown of Medicine Lodge, Kansas, and was hit at highway speeds by a car coming up behind him, texting and not paying attention to where they were going. He survived the initial impact, but it was a windy day and he wasn't able to be transported to a trauma facility because no air or helicopter were flying that day. So he went to a local hospital to be stabilized until transport could be arranged. He was there for 3 hours, never got any labs, never got any imaging, and essentially slowly bled to death from a pelvic fracture over a 3-hour period before anybody could get there to help him out. So the culmination of those things, and me asking why is there nobody there to provide good care for these patients? Why don't they receive the outcomes that they should be expected to receive? Led me to decide, why not me? Next slide, please. So in Hollywood, this is what rural practices look like. This is Virgin River. This is the doctor's offices where she practices at with the hometown doctor. Next slide. Same with Doc Hollywood. For some reason, when you think rural medicine, it's always practiced out of an old house somewhere. But in reality, next slide, please. This is more what it looks like. These are some of the hospitals that I cover. I cover facilities, community access hospitals that are in towns of usually 2,500 people or less. And next slide. And this is my hometown of Medicine Lodge, where I practice nearly full-time now. I still do travel to other rural hospitals some, but it is a 22-bed hospital with 3 emergency room bays, and we do acute patients, long-term care, and swing, in addition to clinic and emergency services there. Next slide, please. So in Hollywood, this is the accommodations that the providers are given. Mel gets to stay in this luxurious cabin in the woods, whereas poor Dr. Stone is left to sleep in the emergency room with the locals coming in and out bothering him for their needs. Next slide. And in reality, this is more what it looks like. This is rural Iowa. My first night there, the hospital that I was working at provided housing at a long-term care facility. So I was able to bunk up with some of the residents there and had a nice little room in the middle of a blizzard. Next slide. That's rural Iowa, where I go a lot. Next slide. And some of the places that I go to in Iowa and Kansas in warmer weather. Next slide. Next slide. So these are what the accommodations usually look like when moving from hospital to hospital. Some hospitals provide a hospital room for the providers to stay in. Others, like the one shown before, it's more a room like this for providers to rest, make their food, rest between ER calls. Next slide. And next slide. So what it looks like in rural America, community access hospitals for the provider. Call is usually a 24-hour shift working in the ER. You cover 5 to 10 shifts per month. And when there's not a patient in the emergency room, you don't have to be in the actual ER itself, but have to be able to get there within about 10 or 20 minutes. You're often the only provider in the building and sometimes in the town. There's not always a designated ER nurse. Usually there's 2, sometimes 3 if you're lucky, nurses working in the whole hospital. So there are no specialists or subspecialists. That's one of my biggest complaints, is when I need to get a patient transferred and the transferring physician at the acute care facility or level 1 trauma center says, "Does your trauma surgeon not take care of patients like this? Has your cardiologist not seen this patient?" And I'm the cardiologist, trauma surgeon, whatever else is needed that day. So we do have specialists who come 1 or 2 days a month, usually cardiology and general surgery. But for the most part, it's just 1 or 2 family practice or emergency room providers staffing the whole place. No OB services, but there's inevitably somebody who comes in to be checked to see if they're actually in labor, and the baby is crowning. So you have to be prepared for those surprises too. You have to be comfortable in a wide array of settings. In my hometown, I cover ER, hospital, have started a Botox clinic and wound care clinic. So kind of a jack of all trades. Next slide, please. So in most of these community hospitals, the around-the-clock services are emergency room care, lab, but the lab technician has to be called in, and basic imaging. The radiology technician also has to be called in. And then for CTs, the results have to be sent to a third party to read the results. Things like MRI, ultrasound, echocardiogram are limited to a couple of days a week or times per month. And the community access hospitals also offer rehabilitation services. Long-term care, over 75% of small community access hospitals offer long-term nursing care. And then primary care, over 70% of rural hospitals operate 1 or more rural health clinics. And most of these rural health clinics have more than 10,000 visits per year. Next slide. So what it looks like, some of the hospitals practice completely independently. Others will use a teleneurologist for things like stroke and TIA that can be consulted to weigh in on those patients. Some ERs work with a third-party company to help consult on trauma cases, more severe cases, and help get that patient transferred to an acute care facility. And then some hospitals hire telemedicine groups to manage their inpatient population while the locals manage the clinic and the ER patients. And transfers in the town where I work, the nearest level 1 trauma center is 70 miles away or 90 minutes away. You have to get the patient accepted before you can start the process going. Must be accepted by a provider at the accepting facility. And our local ambulance service in most places is just EMS, BLS. So they're EMTs, not paramedics, not nurses, just EMT volunteer providers. So outside ground and air crews can be called in, but it has to be after the patient's been accepted at the facility for a transfer. And Doc Hollywood, this is the old doctor who worked there, when to call me: "You've been stabbed, shot, poisoned, separated from an appendage, knocked or beaten unconscious, run over by a tractor mower, or generally about to bleed to death. Otherwise, leave me alone." It's not actually that way, thanks to EMTALA, the Emergency Medical Treatment and Labor Act. It was enacted by Congress in 1986 as part of the Consolidated Omnibus Budget Reconciliation Act. Next slide, please. It's designed to prevent hospitals from transferring uninsured or Medicaid patients without a medical screening examination, and requires Medicare participating hospitals with EDs to screen and treat emergency medical conditions in a non-discriminatory manner. Provisions: the providers and hospitals can be penalized for refusing to provide necessary stabilizing care for an individual with an emergency medical condition or for failure to facilitate an appropriate transfer. Any individual who presents and requests must receive a medical screening exam to determine whether an emergency medical condition exists. If an emergency medical condition does exist, treatment must be provided until it is stabilized or resolved. If the hospital lacks the capacity to provide needed care, an appropriate transfer must be facilitated. And hospitals with specialized capabilities are obligated to accept transfers from hospitals who lack the capability to treat unstable emergency medical conditions, as long as they have availability and are not on diversion. Next slide, please. And this is what the EMTALA form looks like that we need to fill out. We let the patient know or the family member know the risk of transfer, the mode of transfer, which facility is the patient is being transferred to, accepting doctor, and then the provider's signature that the transfer is necessary and why. Next slide, please. So this is what it looks like. Why does it matter? In the US, 1 in 5 people live in rural areas. Millions of people living in rural areas depend on their community's hospital. Providing care close to home improves delays in receiving emergency care, improves prenatal care and access, helps in management of chronic conditions, and allows for early detection and prompt diagnosis of acute issues. And these hospitals are economic anchors in the areas they serve. Next slide, please. As this graph shows, 46 million people, or 14 million of the US population, live in rural areas. Rural hospitals support $220 billion of economic activity. Rural hospitals support 1 in 12 rural jobs in the United States. Over the last few years, rural hospital costs have increased significantly for labor, drugs, and supplies, resulting in 136 total closures in rural community access hospitals from 2010 to 2020. 70% of closures happened in states where Medicaid expansion was not in place. 19 closures in 2020 alone, the most of any year in that decade. Next slide, please. And we know that there is health inequity between urban areas and rural areas. More than 50% of vehicle crash-related fatalities happen in rural areas, even though less than 1/3 of miles traveled in a vehicle occur there. In rural areas, there is an additional 22% risk of injury-related death. Rural areas have more frequent occurrences of diabetes and coronary heart disease. Mental health creates new challenges in rural areas, such as accessibility. Rural residents often travel long distances to receive services. Next slide, please. Chronic shortages of mental health professionals exist. Acceptability, the stigma of needing or receiving mental health care, and fewer choices of trained professionals. And in rural America, you are twice as likely to commit suicide as a result. Next slide, please. And here's some more statistics. Percentage of the population living in rural America, 19.3%, urban, 80.7%. Number of physicians per 10,000 people, 13.1% in rural, 31.2% in urban. Number of specialists, 30% rural, 263% per 100,000 people in urban areas. Next slide, please. And you can see the discrepancies in income, minority population, adolescents who smoke, 11% rural areas, 5% in the urban areas. Male life expectancy, 76 years in rural areas, 74 in urban. And then female life expectancy, Medicare, Medicaid beneficiaries. Next slide. So those issues are why rural healthcare is so important, but can they be saved? Next slide. This is another clip from Doc Hollywood back in the day before Medicare, Medicaid got involved in insurance companies. This guy got his foot fixed by the doctor and didn't have any money, so he paid him with a pig. That's never happened to me in rural America, but I have received cakes and pies and cookies and that kind of thing, which are always welcome, but they still get charged. Medicaid expansion. All right, regardless of political or economic standpoint and opinions, the facts are in Kansas, where I work most of the time, since Kansas has had the opportunity to expand Medicaid, 8 rural hospitals have closed, and 57% of Kansas rural hospitals are in danger of closing. Medicaid expansion reduces the amount of uncompensated care hospitals provide. It increases access to care for patients and bridges the coverage gap, thereby improving overall health outcomes. And in states that expanded Medicaid under the Affordable Care Act, hospital uncompensated care costs in fiscal year 2020 totaled 2.7%, well below the 7.3% figure for hospitals in non-expanded states. Next slide. That's one way that rural hospitals can recoup their monies. Another is the 340B program. Section 340B of the Public Health Service Act requires pharmaceutical manufacturers participating in Medicaid to sell outpatient drugs at discounted prices to qualifying organizations. Organizations that provide services to a large number of uninsured or low-income persons. These organizations include community access hospitals, safety net hospitals, community health centers, rural referral centers, etc. Enrolled hospitals can achieve average savings of 25% to 50% in pharmaceutical purchases. And the 340B program generates valuable savings for eligible hospitals to invest in programs that enhance patient services and access to care. And that works like, say the government provides these, or sorry, the manufacturers provide these rural hospitals with $30 billion of medications. The hospitals can then sell that $30 billion worth of medications for an average of $60 billion and keep that money to develop themselves, health programs, benefit the patients in the community. And third, swing bed. A swing bed is a physical hospital bed that can be used for 2 purposes, acute and post-acute care. The same patient can swing between the 2 acuity levels. Swing bed hospitals must meet the following requirements: be in facilities with less than 100 beds, located in rural areas, contracted with Medicare, compliant with all skilled nursing facility requirements. Next slide. The reimbursement swings from the same patient initially billed for acute services to subacute services. Rural patients who find themselves too ill to stay in their urban hospital, but still too sick to go back home to their rural homes, can return to their rural community hospitals for further care. And they do have a 3-day qualifying inpatient stay before they qualify for swing bed, though that waiver was done away with during COVID-19. So benefits for patients: patients get to stay locally, families can visit, less disruption to care, providers can check in on patients, better continuity of care, access to necessary specialized equipment like infusions that are not found in nursing homes. And for the small hospitals, it helps fill empty rural hospital beds, removes restrictions for a separate facility for post-acute care, and reduces readmission rates. Next slide. So, will rural medicine live happily ever after? Well, I don't know about all hospitals, but since returning back to my hometown hospital, my dad sustained the same exact pelvic fracture that our friend Bob Christensen sustained and died from back in 2019. And my dad lived to have the pelvic fracture stabilized and is in a wheelchair for a few months, but he's still with us. And that is due to better care, implementing better guidelines in the rural areas, and being able to get people accepted and transferred more quickly. And in both Doc Hollywood and Virgin River, the main characters move back to these rural communities or move to them, find love with a small town local, and live happily ever after. And that's kind of what's happened in my course too. The end. Yeah.
Thank you so much, Kelly.
Yes, thank you. That was great. It was really good to hear your perspective on being a provider in rural America, and also just the breadth of topics that you covered. So really, I have a lot of things I'd love to chat about, and I want people to, keep dropping things into the chat. I'm wondering if we do have our final speaker on. I'm not sure if she's able to join us. She may have had an emergency, but is Kay Miller Temple on with the Center for Rural Health?
She did report that she was having a family emergency and that she would try to join if she could see a clearing to join by phone and present that way. But if we don't see her on, we can move to discussion and Q&A. Stacy, did Kay raise her hand or?
No, I'm looking in the attendees and I'm not seeing her, or any phone numbers. So I think probably not. So that means we have time for some discussion. So I don't know if Carrie Bruffett, I'd love to hear your perspective, especially with your role, but also maybe addressing the question that you have.
Thanks, Stacy. I think just a question from the HRSA perspective. Now you're talking about the rural or the critical access hospitals, but here since last couple years now, that there's been the opportunity for some of the rural hospitals, whether those critical access hospitals or small PPS hospitals, to convert to the rural emergency hospital status. What have we learned? So far, what are we learning? And now that there's 30, I looked it up over here, 31 of them, I think, as of per the Shep Center nationally. Not a ton, none in the Kansas City metro area on either side of the state line, but certainly some both in Kansas and Missouri. But just overall, anything that can be learned from that and what that might mean for other rural hospitals moving forward?
Hi, Carrie, this is Lorraine. Can you hear me? I do not have the answer to that question. We work in different silos within the hospital state division. So for me, it's specifically the quality space. I know I have a technical assistance partner on the line. I don't know if she has the answer to that question, but if you would, oh, she is here. Her name is Ann. And I don't mean to put you on the spot, Ann, because if you don't have the answer, we can always circle back.
Yeah, I gathered this question and wrote it down so I could think about that and, gather other people to get some point of view. But I can tell you from a data measurement perspective, they are having the rural emergency hospitals start to collect data. It's not as intense, as in the critical access hospital or other larger hospitals, but they are collecting some emergency room data. And it's just so new that you know, I don't think anyone's seen any trends yet in what they're reporting. But it's good to know at least that they are having the rural emergency hospitals collect data so that we can answer a little bit of what you're asking here.
Yeah.
That's what I can say at this point.
Well, thank you. I love to
Yeah.
keep up with that. I'm no longer on it, but I was for a while on the National Advisory Committee for Rural Health Health and Human Services when we developed like recommendations about the quality measures for REHs. So yeah, as I understood them, they are collecting not quite MB quip, but something some subset. So yeah, I was very curious about when we might expect to see some of the results of that and just overall kind of the, not just the quality data, but just, you know, the experience data. What are those hospitals experiencing? So, but as you said, maybe it's too early to be able to make any conclusions, but I'm really curious about that. And maybe at a future meeting we can discuss. Thank you.
Thank you.
In recent years, we have become held to the same standard for national guidelines for things like sepsis and hospital readmission rates for pneumonia, congestive heart failure, that kind of thing. So we are held to those standards now, and I think hopefully we'll soon have the data to reflect the outcomes.
Thank you all. You bet.
Yeah, is there anyone else online who has any other questions they'd like to ask any of the panelists? Otherwise, I'm going to turn to the chat in just a moment. Although I also have a really high level one, so maybe I throw that one out there first, because I love elephants in the room and addressing them. So I would love to hear, and this is completely a non-partisan session, but I'm very curious. You know, we are about to change administrations, right? And so I'm very curious to hear, especially in terms of rural America and just each of the different organizations that are on our panel today. I'd really love to hear your perspectives on at least what we, you know, again, we don't know for sure what will happen under our new Trump-Vance administration, but we do know enough about some of the things that have been proposed in regards to, you know, the RFK Making America Healthy. I'm just trying to think about things that are affecting rural America, and in terms of, you know, like the agricultural subsidies or changes, things about the proposed tariffs or clean energy or immigration changes. And so I'm just curious, like, especially from your perspective on from a health perspective on each, you know, each of your own organizations, which would be, you know, HRSA, your own programs or the critical access hospitals or support, you know, in terms of Derek, Darren, with like your understanding of the PBMs and the whole landscape of integration in hospitals and PBMs. And then also, you know, Kelly is obviously as a provider who works in these settings and sees these individuals. I'm just very curious to hear, and people don't have to speak partisanly. I mean, it can be very objective about what we think we know or how we think things will change. But I'm also really curious about that because it seems like there are a lot of very different agendas and plans in terms of things that would impact rural America. If anyone feels
Absolutely. I'll go first. You know, who should qualify for Medicaid, who should receive Medicaid is beyond my pay grade. And we all have differing opinions on that. As someone who provides care in the emergency room, it is frustrating that Medicaid patients can come in for anything and don't have to pay the co-pays and things that people with regular insurance do have to pay. But it does generate income for our hospitals and keeps our community access hospitals going. So though it's frustrating at 2 a.m. when somebody comes in with a rash that's been going on for 3 weeks and they just couldn't sleep at night and decided they wanted to come in to be seen then, those Medicaid patients, you know, we are reimbursed for them. And as far as the 340B program goes, there's, especially with pharmaceutical companies, they aren't thrilled with having to give their product to these small hospitals for discounted prices. I think it's something like 23% discount for brand names, 13% discount for generic name products. And then the hospitals can go and sell and profit off of that. But it is one of the few ways the small hospitals are able to recoup monies. And I do have a statistic. In 2022, drug companies provided an estimated $46.5 billion in discounts to 340B hospitals, roughly 3.1% of their global revenues and 7% of US revenues that year. So it does cost these poor drug manufacturers some money, but in the scope of things, it's not a lot of their profit that's being taken up.
From a pharmaceutical standpoint on the new administration, in Trump's previous stint in office, he said multiple times that pharmacy benefit managers are a problem and something needs to be done about them. And then he did, said he was going to do things like making whenever a med is a commercial for an expensive specialty medication is on TV, that they require to have the price of that medication on there and things like that. But nothing really came to fruition. I know from our standpoint, when he was in previously, Secretary Azar was his HHS appointment, and we were very, very close to passing some really meaningful PBM legislation, and somebody in the Trump White House killed it. So I'm hopeful that he will re-uptake his interest in pharmacy benefit managers and the problems they're causing in the healthcare industry, and actually do something about it. And I know Medicare is an absolute mess. I think everybody on the call would agree with that. And with people being, coerced to do advantage plans in some cases, and they aren't very friendly to rural hospitals as far as reimbursements go. And they're even worse to pharmacies as far as reimbursement goes. And so a lot of pharmacies are choosing not to participate in a lot of Medicare Part D plans this year. And so that'll limit access to medications, unfortunately. And so I'm hopeful somebody can get in there and straighten that program out. In 2026, the government has the IRA coming up to where they are basically negotiating the price for the top 10 drugs in the Medicare system. But they've yet to determine how that's going to happen next year. And so it's going to be a complete disaster if it is not well thought out and planned like today. So it can be implemented in 2026. So it'll be very interesting to see what happens in the Medicare realm with this administration, and if they actually tackle the PBM issue.
Yeah, it's interesting. Yeah, and the price transparency across the board. Yeah. Mhm. Let's see. And unless I know, Lorraine, is there anything else you wanted to say on that about any changes and potential impacts for rural health?
So prior to coming into rural health, I was with a BIPIC within HRSA, so I worked frontline with the health centers. So shifting gears a little bit, I would hope to think that rural health is a bipartisan effort, right? But when we talk about immunizations and RFK coming in, we don't, of course, this is above my pay grade as well, but just in thinking, hoping that the immunization measure will still be in place just because it's necessary. Those are just my immediate thoughts. But because it is a bipartisan topic, we're hoping that there won't be many changes, but we just don't know yet. So that's kind of like
Yep. Yeah. No, totally fair. And also very true. Immunization as well. I hadn't brought that one up either. Yeah. Okay, great. Well, and then there's I just want to check, unless Kay joins us, if she ever does, just come right on off mute. But I'm not rechecking. But there are a couple other comments, just looks like for Darren related to pharmacy. So there was one here. It says, what role, if any, are online pharmacies, such as Amazon Pharmacy, playing in drug pricing and the pharmacy landscape generally, especially in rural areas? And do we see online pharmacy use growing? And then I had just asked, I guess, a little bit of a follow-up, but also similarly about online pharmacy growth, and then particularly related to rural. I'm just, I was very curious if this is also very much like the small bookstore kind of analogy where these mom and pop shops are just going to be forced to not exist anymore, as wonderful as they are. And as the pharmacist in certain communities can be a great asset to
Sure.
people there. I'm just, very curious to hear your thoughts and
Yeah. Well, and it's not even a mom and pop pharmacy issue. I mean, Walgreens is closing 1,200 stores, and so nobody is surviving this landscape. And since the PBMs own all, their own pharmacies, they don't really have to offer you a good contract. What a contract negotiation with them looks like is, here's the contract, sign it. Oh, you don't want to sign it? Okay, we'll just force everybody to use our mail order pharmacy, is what it looks like. So, and I think downtown Boston has a pharmacy desert right now. I don't think there's pharmacies in Boston proper. I saw an article about that today. So it's kind of a crazy deal. It is a rural issue, but it can also be an urban issue as well. Um, but in regards to online pharmacies, I mean, they probably will grow, unfortunately. Like Amazon and some of these guys, I mean, I don't know that it'll grow massively because they see similar reimbursement to what we do. And so, it's not a great moneymaker for Amazon to have a pharmacy. You'll see the use of PBM owned pharmacies uh, go up, unfortunately. Just as more pharmacies close, that's going to be the only option for people. And what scares me about it is, what do we do about antibiotics? What do we do about immunizations and vaccines, and all the other things that pharmacies do? I just don't know. In a lot of counties, especially in Kansas, a pharmacy may be the only healthcare provider in the whole county. And so what do we do in those situations? And then, there's nobody likes to do mail order pharmacy. I mean, um, we had a gentleman from TRICARE come in the other day, and they are forced to use mail order pharmacy for any brand name medication. And it was Dupixent, which is a refrigerated item. And when he got it, it was steaming hot. And so they don't have to. I mean, there's no rules about when they ship those type of things that they stay temperature controlled. And so what happens there? And who answers their questions? Nobody likes to call the insurance company and wait for an hour on the phone to talk to a human, right? So who answers their questions about how to use a medication and what it's for and how long they expect to be on it and all the things that a pharmacist can do. So it's very troublesome for me that those things are occurring, but unfortunately they are. And so yeah, the use of mail order pharmacies will continue to increase. And I don't think, to answer your question about it being unsurvivable, I don't think that's the case. I think pharmacies are evolving to offer more services outside of just dispensing medications. And so there are a lot of things that pharmacies are doing to make money and provide good health care besides just the dispensing of medications. Sorry, that was
that's helpful. No, that was great. Are there anyone else on? We do have it looks like 24 people on right now. Is there anyone else who has questions, anything at all, wants to chat with our panel about?
I'd be curious, sort of in the theme of the haiku, thinking about what, potential quality initiatives, what, even research or something. I don't have an answer to my question, so I don't know if anybody else will, but really sort of thinking through, hey, a lot of the things we talked about, we're talking about today's impact rural communities, which certainly are part of the service area for IQ, but also not the largest population area. So I wonder where there's some overlap between some real areas of potential interventions or quality initiatives that you could do in Jackson County and Johnson and Wyandotte County, but also in the outside the more metro part of the metro area. And so thematically, that's what I'm sitting here thinking about is like, where are those connections? What Darren's talking about isn't unique to rural. So, and 340B is not unique to rural. So I'm kind of curious where that intersection is that might be really interesting, and that we know then maybe would have an outsized impact in rural communities as well.
No, I mean, as a high IQ representative, I feel like I should answer some of this, but I want to hear from the panelists as well. But immediately, actually, when Kelly was presenting, I thought that it was interesting. I mean, when you just think about how the practice of medicine is so much more generalist, right? I mean, that's kind of what you're also describing is you've got to be ready for everything, right? And because you're not reaching the volumes of, say, the same procedure or the same thing all the time, so you're receiving everything in that community. And so I remember seeing one of the slides you had where it was about prenatal care and maternal care, and I think especially as high IQ kind of moves into our next big topic of really trying to think through maternal health inequities and disparities and how we can overcome those and improve across the pregnancy life course, from conception through into postpartum, how we can support women and their babies or birthing peoples, I guess we say, and their babies. But we were thinking, I think some of that interesting handoff could be in how we move from, like OB, high risk OB care into how do you translate that into primary care, and when people go back home and are in their communities, and some of that handoff of monitoring high risk and how we're watching them with telehealth interventions, with blood pressure cuffs and communicating to providers. And so at least my obviously I'm trying to focus on at least the synergies by which we're already developing our interventions. How are there ways to connect to rural primary care and other settings such as that, so we can actually help in a bigger way. But I would love to hear other people speak. I don't have to speak only to maternal health.
There was a recent article in the Lancet about telemedicine in rural areas, and maternal health and infant outcomes were improved at facilities who use telehealth in the clinic area and in the emergency department for the unexpected deliveries. Outcomes were improved. And similarly for ICU transfers to larger hospitals, those were decreased in facilities that utilize telemedicine consults. So I think there is room there for rural hospitals and urban hospitals to collaborate together to take care of patients. And then the urban hospitals don't feel like the small town hospitals are dumping on them, and the small town hospitals don't feel like they're being abandoned by the larger facilities.
I wonder, Wyatt, I'm reading yours out, but do you want to come off and say it out loud? Otherwise, I'm happy to read it.
Sure, if my dog behaves long enough to scare us off. Yeah, I think it's an interesting discussion when we get into, especially when we set it up as urban and rural. One, we often talk about those as sort of distinct, like opposite ends, like a clean dichotomous sort of descriptor, and it's a lot fuzzier than that. It's really a continuum, and there are unique dynamics, on size and proximity and location, all these other things. So there's already, just starting from that place, recognizing more complexity. But I think the danger in talking and strictly saying these are only rural things, these are only urban things, is that we miss that there is an opportunity in most cases for collaborations, for synergies, that that bridge that urban-rural dichotomy. And there are insights that we can likely learn when we're open to learning from a range of perspectives and locations and approaches to these issues. But at the same time, we have to recognize that there are unique things about rural challenges and context, and sort of balancing both of those, which can feel are at tension, that like there's shared things here and there's unique things, there's an inherent tension there. But if we can balance that, I think our best insights will come from trying to hold both of those things at the same time.
Yeah, I think that's a great point. I want to be mindful of time, but also if there's anyone else who wants to ask any other questions, I also want to entertain it. At this time, I know otherwise we are at, 4:27. I just, while we're waiting, if there's anyone else that wants to chime in, you're more than welcome. But I just wanted to share, since you all know this is the last forum that we have for this year, that here's our which is very interesting, especially for how much coverage we just did today talking about drugs as well. But we will be talking about drug costs and parity in January, and then you can see kind of the rest of our agenda for the year. And yeah, we're very, very excited to keep the forums going and these dialogues, and hopefully we have some all connected new people, new names, new connections, which is also a really wonderful thing we love to do in these forums, is build new connections and networking amongst people who maybe didn't know about each other before, and we can build new collaborations. So I really just want to thank all of our speakers so much for your time and energy, and thank you all.
Yeah, and thanks to those who signed up to attend in person. Thank you for your quick shift to virtual. We're sorry if it was an inconvenience, but thank you.
It was appropriate. Telehealth, tele delivery. Okay. All right.
Thank you
Thank you
very
all.
much.
Thank you
Thank
all.
you all.